Hello,
Hello, how are you?
I'm doing just fine. It's good to see you.
You too.
It's been a little while.
It has. How are things?
Things are good. We've been busy as always, but
Yeah,
okay.
I know. I
Yeah,
know. I feel like it just continues to get busier. Like there's never a time I'm like, wow, things have really cooled off.
yeah, that is a wish and a dream. Something that I remember. I was just telling a fellow the other day who's about to graduate. How I always thought being an attending would be such a more laid back experience than fellowship, and of course that's further from.
We were all very misled.
We were lied to, really. Well, thank you again for doing this. I
Absolutely.
probably been 3 years. I think it was 2020 maybe when you did this.
I know. I
My
was
mind
looking
was
back at
like
my
last year.
slides.
Yeah.
Yes. It's crazy. Time flies.
Yeah. So I feel like this is such a black box for us hepatologists of something that we should know better than we do.
Yeah.
But you all do such a good job of managing these patients, makes it easy for us. But I think my biggest question, which is similar to probably what it was when we did this before, is what patients should we be referring to? I guess as systemic
Uh-huh.
treatment has become more mainline for patients that are not HCC candidates. At what point, our default if they're in Milan or just outside with HCC is just to do local regional treatment and things like that. But
Yeah.
your role now for earlier systemic treatment. So don't have
Yeah.
to answer that now, but I just
Yeah, no, absolutely. And I
yeah.
think that's the thing. Like, so I'll share a slide. We just had our GI oncology meeting
Mhm.
like last weekend.
Mhm.
And, it's evolving so quickly.
Right.
And now, there's not definitive data yet, but I mean, we're moving to the point where we're going to be combining immunotherapy or, some kind of combination systemic therapy with liver
Right.
directed therapy. So my
Right.
guess is earlier and earlier,
Yep.
but we'll
Exactly.
talk about it too.
Well, good. Well, good.
I'll get my slides shared here.
All right.
All right. Are you guys seeing the correct view?
Nope, we're seeing your
Okay.
like the presenter view. Yep, that's the one.
That's it? Okay, good.
I don't know why that comes up as a default every time. It
Always.
seems to be doesn't make any sense. I think let's if you don't mind, just wait a minute or two. I see people
Absolutely.
logging in here.
Such a weird day today. Like this
Yeah.
morning, I thought we were going to be snowed in, and now it looks like spring.
Yep. Sun is out.
We'll take it.
Welcome to Colorado. And is it all right if we record this? We have a few people that won't be
Yep,
able to make it that requested.
of course.
Put it in
Not
the
a problem at
archives.
all.
It won't be on YouTube or anything else.
You're not going to make a TikTok video out of.
I'm not the one to do that, but we can try. Yeah.
Oh, surely there's someone in the crowd who can do that.
Yeah. Actually, if Lindsay Carter, if you don't mind hitting record, and we'll go ahead and get started. And just as a means of introduction for those of you that are joining us, Lindsay Davis has graced us again this year to give this update lecture on systemic treatment for HCC, which I think is such an important topic as it affects a lot of our patients. And I feel like, unfortunately, our worlds are too divided in terms of what we do in the hepatology world and what's been happening in the medical oncology field of treatment of HCC. And so I really appreciate this opportunity to educate all of us, because this is a topic that we certainly could use more education on, given the rapid developments in this field. So Lindsay, without further ado, thank you again for agreeing to lecture us.
Absolutely. Thanks, JP. And thanks so much for the opportunity. I always look forward to talking with you guys and always value seeing and sharing patients. So of course, anytime you guys have questions from the oncology side, don't hesitate to reach out. I have my email on the slide at the end, but always happy to talk about things if there's questions from what we can do or should we be doing on the med-onc side to help support your patients with HCC. And this is my clinical focus. So I see all cancers of the GI tract in the cancer center here at Anschutz, but particular interest in HCC and cholangiocarcinoma. Just excited today to kind of fill you in on updates. I was just saying that we just had our GI oncology focused meeting of the year last weekend, and even have some stuff to update from that. So it's definitely a field of excitement and interest from patients, providers, companies developing drugs. So a great time to get into HCC as a field. And let's see if I can, okay. So this is just brief outline for today. I wanted to start with a little bit of background. I'll try not to go too med-onc on you here and give a little bit of understanding of the classes of drugs and kind of big picture areas that we're targeting with these systemic therapies. And then we'll talk about emerging role of systemic therapy in early and intermediate stage HCC, and then really talk about where we have approvals at the current time, which is an advanced stage disease, and what those look like. So let's start with a little background. So I show this because it's not that long ago, less than 20 years ago, the AASLD practice guidelines basically said you should not give any patient with HCC systemic therapy. And that is in contrast of today, where this is a list of the FDA approved systemic therapies for HCC. And you can see that there's quite a list. Sorafenib being the first as of 2006 was the first time we had, actually 2008 was the publication, was the first time we actually had an option to provide patients with medical therapy. So back when I was a fellow, this talk was short. We talked about sorafenib and that was all. But since that time, you can see there's been a significant number of approvals in various areas. We'll kind of walk through what these drugs are in general, kind of general classes. And just to note that to the point that this is still an ongoing area of interest, that I had to add even a new therapy that's just been approved in the last 1 year to this 2022 publication image. So always advancements and more to come. All right, so just to give you guys a general sense of what we're looking at targeting for the approved therapies for HCC and areas that most of the ongoing clinical trials for systemic therapy are focused on. So this image is from a review paper. You can see they're depicting here the HCC cells. And I want you to notice that though you can see a lot of different receptors that these drugs are hitting on the surface here, KIT, FGFR, these are all tyrosine kinase inhibitors, so that are hitting these, basically these proteins on the surface of the cancer cell. Not important to remember all these things. Really what I want you to note is that all of these variety of receptor targets with lenvatinib, sorafenib, cabozantinib, regorafenib, they're all also targeting the VEGF pathway. So really, we believe that though these drugs are kind of variable in the spectrum of what kind of proteins on the cancer cell surface they hit, the key factor that they all share is that they are inhibiting the VEGF endothelial growth factor pathway. So this is the vascular endothelial growth factor that helps the blood vessels grow. And that is one of two kind of key areas. So this was the original area. This is sorafenib's target. This is where all the other drugs kind of similar to that tried to do better or equal to sorafenib, until cancer immunotherapy came to the forefront. And that is now where we go from VEGF targeting alone to thinking about, do we combine it with, for example, cancer immunotherapy? And the big targets here that you'll hear about are the PD-1, PD-L1 axis and CTLA-4 axis. And basically all you need to think about here is that these cell surface receptors on the T cell are what help the immune system prevent autoimmunity, right? So what we're saying is that these are natural receptors that help inhibit too much autoimmune response in the body, but the cancer cells activate these receptors, which then leads to the immune cells not recognizing cancer cells and fighting it off. So the big breakthrough was targeting these cells to allow our own immune system to recognize our cells, our cancer cells that are foreign to them. And that was Nobel Prize winning, and is really where the forefront of cancer care across diseases has come at present day. So key takeaway, VEGF inhibitors, immune checkpoint inhibitors are really the two classes of drugs, or the focus and targets of the drugs that you're going to see in approvals and in clinical trials moving forward. So I think the last piece of background I want to share is just a walk through kind of where it all began. So this is, we're going to dive into sorafenib a little bit for two purposes. I think the first is just to kind of understand why all the subsequent clinical trials were designed as they were. And it was based on how this drug got approved. And then also just to kind of point out the key things we look at from the med-onc side to determine if a drug is important and relevant to our patients and where we might consider combining therapies in terms of toxicity. So again, sorafenib is one of those multi-kinase inhibitors. We think VEGF, the vascular endothelial growth factor, is the place that it's most important in HCC, but hits a number of other targets. So this is the trial that led to the approval of sorafenib, first medical therapy approved for HCC back in 2008, published in New England Journal. And it was a phase 3 randomized double-blind placebo-controlled trial because we had nothing else better medical-wise to provide at that moment. It was randomized 602 patients, and it was a 1-to-1 randomization. Sorafenib is an oral drug and compared to placebo orally as well. I think the key thing I want you to remember at this moment is this study basically decided they were going to use child class as the assessment of the underlying hepatic function of the patient. So to decide, is a patient fit enough to enroll in this clinical trial from a cirrhosis standpoint or from a hepatic function standpoint, they selected child class and limited it to child class A. And every other systemic therapy trial since that time has done the same. So that's where we get it from. So in the oncology world, we are specifically focused on overall survival as kind of the gold standard primary endpoint for all of our clinical trials. There are some caveats to that, and we'll talk about it a little bit in upcoming studies. But I think the key is this overall survival improvement was the first ever seen with a medical therapy. I can see that you may be underwhelmed by the median overall survival of 10.9 versus 7.9 months. It was statistically significant with a hazard ratio of 0.69 in that study. And so you can also see the bar is kind of low from starting out that we're improving survival to 10.7 months just by about a 2-month margin. The other things that we look at in these clinical trials as well. So we also think about how long is a patient on this treatment before their cancer progresses. And we can look at that in various ways. They did it in a slightly different way than most of the current studies do. So instead of progression-free survival, we'll say, they call it time to radiographic progression, but also looked at symptomatic progression. Interestingly, patients' symptoms didn't really differ too much between placebo or sorafenib, but imaging-wise, they did see a significant delay in the time to progression by a couple of months. Then the last thing that we'll talk about as an endpoint, especially in earlier phase, like a phase 2 trial, is how are the cancers shrinking? Are the tumors shrinking on the study? And that's what we mean by response. You can see in this sorafenib trial, no patients had complete disappearance of their cancer. We wouldn't expect that. These are advanced HCCs. But very few also had any shrinkage of their tumor. This is measured in a very common way, like across all clinical trials for oncology agents, but only about 5% of patients had any kind of shrinkage of their tumor that was considered significant. And then the last piece that we really care about is what is the toxicity of the drug? And, it's exciting for patients, I think, to think about, when you come and meet the oncologist, you think you are getting IV chemotherapy, right? Like people consider anti-cancer therapy to be chemo in a port. But these drugs, these tyrosine kinase inhibitors in general, are all oral, which is nice. But if you think about it, these are also medications you're taking every single day, unlike some of our IV treatments are coming in once every 3 weeks. So there's not off time. You're just getting them consistently. So in this original trial, you can see the key things more than placebo that patients were affected by: weight loss, hair loss, hand, foot, skin reaction. This is dryness, peeling, cracking of the hands and feet that can be very bothersome. Anorexia, diarrhea, and voice changes were the big ones. And none of those are terrible. Like none of these are life-threatening events. Most of them were pretty mild in severity. However, if you're dealing with this for months of your prolonged life, that's where it kind of comes into play, the importance of considering the multitude and the persistence of these toxicities over time. So the last thing I want to point out before we move on is just this long period of time where we only had sorafenib, and then this kind of flurry of activity in the space of approvals for hepatocellular carcinoma. And I think that is not for a lack of trying. So surprising as it may seem, for these 10 years where there were no additional approvals for HCC systemic therapy, there were tons of trials that couldn't beat that median survival of 10 months of sorafenib. So I think keep that in mind. And also kind of just the novelty now for many companies and many providers, honestly, oncology providers in the community, for example, that aren't accustomed to treating patients with HCC with systemic therapy. All right. So next we're going to move into early and intermediate stage disease. And I want to give the big caveat here, which is there currently are no approvals for systemic therapy in this space, but I bring it up because I know it's most relevant to you and brings up a point we can kind of discuss perhaps at the end about how should we integrate us seeing your HCC patients and what is the right moment. And so like you guys, we use BCLC for our HCC patients, which I love as an oncologist because it includes kind of the key things for us, not just the stage, but also performance status and also their liver function, which I think is vital in these patients. And if we're focusing on the very early and early stage patients, typically we're not involved in this group of patients. We don't usually see these people. You guys are managing them, working on resection or transplant or ablation procedures. But I do want to bring up one study that was just presented last year at one of our oncology-focused meetings regarding adjuvant therapy. So is there a role for doing any kind of systemic therapy following a curative intent ablation or curative intent surgery? And I just call out first that this was looked at with sorafenib, right? Like we did everything we could with sorafenib because it was the only thing we had. Let's just try it everywhere. So the STORM trial was published back in 2015, and we found it did not improve overall survival, recurrence-free survival versus just doing surveillance following a curative intent therapy for HCC. So since that time, there's been nothing else that has been effective. And so there is excitement around this study that's only been presented in an interim form. It's called IMbrave 50. And basically this is using atezolizumab. So this is a PD-L1 inhibitor, so one of those immune checkpoint inhibitors, combined with bevacizumab. This is a VEGF inhibitor. Both of these are IV drugs. And they did find that at their 12-month interim analysis, there was an evidence of improved recurrence-free survival. So this is a phase 3 randomized trial. They've randomized 668 patients. The key attributes of these patients are that they had high-risk features following procedure. So they had a tumor that was greater than 5 centimeters, more than 3 tumors. They had microvascular invasion, segmental portal vein invasion. They couldn't have a more extensive invasion of the portal vein, branch portal vein invasion, or a grade 3-4 pathology on histology. They were not allowed to have extrahepatic disease. And again, we're just focused on the child class A population. And so as the reminder, just to throw those pictures up for you again, atezolizumab is the PD-L1 inhibitor and interacting at the immune checkpoint, and then bevacizumab, VEGF, both IV drugs. So this is the survival curve for this study, presented less than a year ago. And I think the reason that it got such notice is because we have nothing in this space at all from a medical standpoint. But I think there's obviously some caveats. Like here, we're looking at a 12-month, so just 1 year following this curative intent procedure is where their curves separate. And, there's not enough data yet, but there doesn't seem to be a continued separation, at least from the data available at that time. They did meet their primary endpoint for the interim analysis, which was the cutoff for this recurrence-free survival event. And IRF just means an independent radiology review. So not just the investigators making sure they didn't have recurrence, it was independent radiologists. So I don't think that we're at the point where we can say, send us all your patients for adjuvant atezo-bev at this time. I think really we just need more time. We need longer follow-up. There's always conversations about this bimodal distribution of recurrence of HCC, and we're only here. We haven't hit this point yet. And also there's not any data at all about overall survival. I think the reason I bring it up at all is just because I think it's an area I'm hopeful. There's multiple ongoing studies that are looking at this space in various different combinations. We have single agent immunotherapies. We have other combinations of immunotherapies from other companies. So I think it's a place where we'll have more data to share, and hopefully will be something that you'll be sending us patients for more for this indication in the future. And then, yes,
can I just
please
interrupt real quick? So
Absolutely.
Are those clinical trials that are going on here? So should we be sending for enrollment in clinical trials?
We have none of these studies open at our site. So not at the moment. Okay. We'll talk about a study we do have ongoing next in the intermediate stage though, which will be opening in the next couple of months. So the next question is, what about combining systemic therapy and local regional therapy? So for those patients who are candidates, TACE is kind of the standard, though, of course, here we do more Y90. But the original clinical trial development focused a lot from the oncology side, combining systemic therapy with TACE. And so this was one of those studies just presented at our meeting last weekend. So it's called Emerald-1. Durvalumab is another PD-L1 inhibitor. So it's just like atezolizumab, just a different company, combined with bevacizumab, again, that VEGF target. And they combined with TACE, and they compared to TACE alone. It was a phase 3 randomized trial, 616 patients. They had 3 arms, actually. So they had a durvalumab alone arm, a durvalumab plus bevacizumab arm, and a placebo arm. And basically, they staged the addition of bevacizumab, the VEGF inhibitor, until after the TACE procedure to not interfere with the procedure itself. Their inclusion criteria: no extrahepatic disease, no significant macrovascular invasion. And this had to be your first line of TACE or systemic therapy. And again, actually, this is one of the unique studies where they've included B7, which we're seeing a little bit more in the more current clinical trials. Again, targets: durvalumab, bevacizumab. And so this is what was just presented in terms of median progression-free survival. So key point, right? They don't have overall survival data yet. It's too soon to analyze that. So this, again, probably not practice changing, but they were very excited about it. And I think opens the doors for consideration that there might be some benefit to adding systemic therapy to local regional therapy in these intermediate stage patients. Their median survival or median progression-free survival with durvalumab bev plus TACE was 15 months versus 8.2 with TACE alone. They did also analyze the data with durvalumab versus placebo, and that actually was not significantly improved. So it does seem there's a benefit of combining the immunotherapy and VEGF targeting in this setting. So I would say 2 limitations for us here at Colorado. We primarily use Y90 rather than TACE in the patients we're seeing, at least in the intermediate stage on the oncology side. And we don't have data yet on overall survival, but hopefully more to come. And here is where there are lots of ongoing studies. These list all of the TACE combined studies, but we have a study opening here called Emerald Y90, which will be open in probably a couple of months, maybe even February. John Lindquist is actually the PI, and I'm the oncology sub-investigator. And the idea is doing this exact same study, but in Y90. So definitely a point where we'll want to be seeing your patients with intermediate stage disease. And John and I will be sure to send out messaging to you guys once it's opening, and you can know how to get us patients. Okay. So that's all I have for early and intermediate. I think summary there is nothing that's prime time ready to integrate into your practice change, but areas of very significant interest across the fields and various companies pursuing these areas. Okay, so let's finish with advanced stage disease. And we like to break it down in oncology by first line therapy and second and third line, basically meaning this is the first time you've had systemic treatment, or you've already had 1 line and you've had progression or toxicity related. So here we have on our BCLC advanced stage disease systemic treatment. And what I want to show you is these are our guidelines. So National Comprehensive Cancer Network, the kind of universally accepted guidelines in the US for how we choose regimens. And I think the key thing with systemic therapy in the metastatic setting at this moment in time is that we kind of have a number of options, and it's a little bit difficult to know how to sequence those options and how to select from this menu. So you can see even preferred regimen, it's not one, there's preferred regimens that you can choose from. And then there's other recommended regimens. And then in certain circumstances, we might use these. So just to kind of call out, I think the key 2 regimens that we consider most, why we might consider one over another in certain clinical situations, and then we'll kind of quickly touch on a few of these areas that I think are helpful for you guys to know. So atezo-bev, you guys are probably most familiar with this data and information from this combination study. Again, PD-L1 plus bevacizumab VEGF targeting, both of these are IV agents. So this is the EMBRAVE 150 trial published in 2020. And basically, they looked at the overall survival with atezolizumab bevacizumab versus sorafenib in a phase 3 randomized trial. They randomized 501 patients. They were all unresectable, so not everyone was metastatic, but they had to have not received systemic therapy, so no other local regional therapies available. There was 2-to-1 randomization to the IV therapies, which is administered every 3 weeks, versus sorafenib, which is twice-a-day dosing oral pill. Again, limited to child class A. I think the key thing here that we bug you guys about is that in the study, they excluded any patient with high-risk varices, and part of the inclusion enrollment criteria were that if you must have had an EGD within the last 6 months and complete treatment of varices as per the hepatologist prior to enrolling in the study. Oh, let me go back, sorry. So this has kind of been adopted in clinical practice since the trial, and why we're often referring you people for an EGD prior to starting this treatment. The other exclusions of this study that are notable, of course, autoimmune disease and prior liver transplant. So those are the two things I see a lot, people walking through my door that I say, well, we've got this new first-line therapy, but you can't have it because you have already had a liver transplant. And we worry about risk of rejection. And then I don't see this much, you guys maybe more than me, but hepatitis B, C co-infection was also excluded from the trial. So this is the final overall survival curve, which is reported a little bit later in 2022, but you can see this is the longest median overall survival ever reported in hepatocellular carcinoma advanced disease. 19.2 months was the median, and that was compared to sorafenib, notably a little bit longer survival for these patients than in the original study in 2008. But still significant improvement in overall survival. For those other measures we like to look at here, I think the key thing to note, and something we know about cancer immunotherapy in general, compared to tyrosine kinase inhibitors like sorafenib, that there's much more tumor shrinkage with these therapies. So atezolizumab plus bevacizumab, about 30% of patients had some significant tumor decrease in size, whereas that was 11% with sorafenib, again, more than the original study where it was only 5%. And then the other thing, duration of response, we talk about a lot as well. So patients stayed on the study for a median of 18 months, which was quite a long time for this population of patients. When we're thinking about toxicity and comparing that to sorafenib, just pointing out the key things that are a little worse with the atezo-bev combination. Key things, hypertension, and proteinuria. So this is well-known toxicity of bevacizumab. It targets that vascular endothelial growth factor, so affecting the blood vessels, leading to blood pressure elevations, protein collection in the urine. And that is not new or worse for this study, but just something different than the sorafenib population. The other areas of interest or difference between the two drugs, there's actually significantly worse diarrhea with sorafenib versus atezo-bev, which is thought to be one potential side effect of atezolizumab, but was much more tolerable. And also decreased appetite worse with patients on the sorafenib therapy. There are more risk of infusion-related reactions, which are kind of like allergic reactions to at the time of the infusion of the therapy. And then fatigue, actually better with the combination. This hand-foot syndrome not seen in the immunotherapy combination. I have arrows next to the LFT elevations that were monitored closely. This was kind of exciting for us in the med-onc side because there was this concern that giving people cancer immune therapy who have underlying cirrhosis would be risky, like we'd induce more drug-related hepatitis, immune checkpoint inhibitor-related hepatitis from the therapy, which was not seen, at least significantly. It was similar to what we see in the general population, not worse because of underlying cirrhosis. So that was our standard of care for a couple years. But then just in this last year, Himalaya trial was published. So this is now looking at dual immunotherapy in the same population. So durvalumab is PD-L1, so same target as atezolizumab, just a different company. Tremelimumab is CTLA-4, which we kind of touched on in that earlier slide. So another target for immune silencing that we're inhibiting with this drug. CTLA-4 is kind of the first area of immune checkpoint inhibitor fame for oncology. It's was the first approval, and specifically in melanoma. So that's used a lot in that indication. So this is a similar design, phase 3 open label randomized trial, 871 patients here. Their randomization was kind of complicated. So they did a tremelimumab, durvalumab, so dual immune combo. They also did an arm that was durvalumab monotherapy, and then they compared each arm separately to sorafenib. They didn't compare their durva to their combo. And then they looked at overall survival for both. Interestingly, they just had a inferiority design for the secondary objective, comparing durvalumab to sorafenib. So they weren't looking for it to be better, just not worse. This also limited to child class A patients. And similarly, because of the immunotherapy component, no autoimmune disease or prior liver transplant. One interesting thing they excluded, particularly here, is main portal vein thrombosis in this trial. So again, looking at durvalumab, just pointing out CTLA-4 is also a target on the T cell, just interacts differently. Instead of interacting with the tumor cell, it interacts with antigen-presenting cells. So this drug in particular has and ipilimumab, another company's version of it, have a reputation for increased toxicity, and especially when we're combining with another immune checkpoint inhibitor. So the PD-1 or PD-L1 combined with CTLA-4, we get many more immune-related toxicities from this. Of course, our biggest concern in this population being immune-related hepatitis. So this is the outcome, the survival curves here, their overall survival primary endpoint. STRIDE is the name they gave their regimen, tremelimumab, the CTLA-4 plus durvalumab, because they just used one dose of tremelimumab. I don't think it's necessary to complicate this more, but regardless, they call it STRIDE. Then in red is the durvalumab single agent, and then in black is sorafenib. And you can see in terms of median overall survival, actually there was not a lot of difference in the median survival between the doublet therapy versus durvalumab alone, but it was statistically significant when each was compared separately to sorafenib. And not that we're comparing, of course, but the actual median overall survival number was lower than that in the atezobev initial first-line study. In terms of response, also somewhat surprising, there wasn't a ton more response when we combined dual immunotherapy to just one immunotherapy drug, but both were significantly greater than with sorafenib. And then the duration of response was significantly longer with the combination immunotherapy versus a single agent immunotherapy, which we'd seen in other disease states. So not too shocking, but something to note and think about if there are select patients where that may be relevant. And then in terms of toxicity here, the big thing, as you might expect, that we saw more of was immune-mediated adverse events that required steroids for treatment. So 20% of patients experienced that. 12% of those were severe, so grade 3 or 4. And then 1.5% of patients died from an immune-related toxicity. Otherwise, the toxicities were, even in the doublet immunotherapy, were not that different from sorafenib as an oral pill. So putting it all together, and I didn't do a deep dive in all these things, but I'm going to point out for you kind of the key areas that I think are important. So are really two kind of standout first-line options that we're considering when we see a new patient in clinic that's child class A are atezobev or durvalumab tremelimumab, a VEGF plus immunocombo or immunotherapy doublet. And I've kind of listed out here the distinguishing characteristics. So we know just comparing head to head the results, of course, the overall survival is a little longer, but we shouldn't compare in that way to make our decision. I think the thing in terms of experience with toxicity that I think about when I'm seeing these people is Bev, of course, is a VEGF, right? And this is a more intense VEGF than sorafenib and lenvatinib and the oral therapies that we have. So if you have a person who you're worried about bleeding, absolutely high-risk varices, perhaps we steer away from this atezobev combo. So I, for example, had a patient, I was about to start on atezobev the day of treatment start. In my office, she has new shortness of breath and chest pain, and I sent her to the ED and she has a PE. So decided not to go ahead with the Bev in that person. So this might be a situation where you reconsider a fit patient child A that you can consider durva-tremi. The thing I worry about this is, and I've had this happen once before, a patient who's actually on atezobev who got immune-related hepatitis and died of it. There's complicating social reasons, but I always consider it here because the risk of having a severe immune toxicity is greater with this dual immune combination. I also consider that the patient, sometimes I'll say, there's not a ton of data for atezobev in a child B patient, but a highly selected person, I'm comfortable with giving them an atezobev combo. Durva-tremi, I am not as comfortable with that, just for this reason, that if we're going to stimulate this immune autoreactivity and hepatitis, they're not going to tolerate that as well as a person who has better underlying hepatic function. So that's been kind of my rationale on how to decide who to put on which kind of therapy. I think there are still specific situations you could consider this durvalumab alone arm, and that would probably be for someone who comes in who's not in the greatest shape, or that's a more of a borderline child class, given we don't have other data in this particular situation. Now, there's still a place for lenvatinib and sorafenib. I didn't really touch on lenvatinib today. I think the key thing about it is it was a study that was published just right before all of the immunotherapy drugs were approved. So it didn't have a great time in the sun, but it was a non-inferiority trial, as I mentioned, to sorafenib. So just not better than sorafenib, but not worse. The key thing about it is it had a much better response rate. So 24% of patients had shrinkage of their tumors versus sorafenib. I think either of these drugs we're considering in those patients we see from you guys that are post-transplant now with recurrent HCC metastatic disease. Also, this is what we're considering for people who have significant autoimmune disease that we can't treat with an immune checkpoint inhibitor. And then the other thing I'll just add about sorafenib is because it's the only thing we had around for so many years, there are some studies specifically looking at use in child class B patients. And so it's the drug that has the most data in this setting. So I feel personally most comfortable using sorafenib over lenvatinib in this setting. The other thing I'll say about lenvatinib too is that it seems to have maybe a more potent VEGF target just from the toxicities I've seen in my patients. And I've had one person who had a significant variceal bleed on lenvatinib. So I have started considering screening my patients who are close to do or do anyway with EGD before I give them lenvatinib. And then the last thing I just want to touch on is you might also see us sometimes do a nivolumab therapy for these patients. The reason we consider nivolumab is because it's the only immune checkpoint inhibitor that has some data in child class B. So though durvalumab, there's an overall survival benefit seen in that Himalaya trial. In nivolumab, the actual overall survival endpoint wasn't met, though the response rate was better. It didn't meet the statistical significance. So I still will use it here and there for a kind of a pretty borderline patient who I think still is a reasonable candidate for treatment. Okay, I know that was a lot. Do you guys have any questions there or want me to go on through the kind of last piece of the lecture, which is beyond first-line therapy?
Oh, sure. I was just going to ask on that last slide, if you don't mind, is there any direct head-to-head comparisons between these, like nivolumab? Why is that kind of you only use in certain circumstances? How does that compare to any of the other ones like durva?
Yeah, great question. There are no head-to-heads of any of these other than this non-inferiority of these two, which are kind of like our lower tier. Probably will never be done to any of these. I think probably what's going to happen is once durvalumab alone has more data in child B, we'll just switch to using that. And I've already started using this as for a person that I'm worried, like, let's say an example where I've used durvalumab alone, someone who I didn't feel had a performance status that was acceptable for a dual first-line therapy, but was still child class A, I've given durvalumab. So I think right now with a lack of data to guide us, we're kind of using these clinical characteristics as the guide. Hopeful that we'll have more information in coming years, but that's what we're kind of using more of clinical presentation at this point. Okay, so the guidelines get even less clear now that we talk about a person who's had cancer growth or intolerability to that first-line regimen. So we know that this guideline group recommended either atezolizumab, bevacizumab, or durvalumab, tremelimumab as one of the primary options. And the trouble is that all of the studies done for subsequent lines of therapy were done with sorafenib as the first line option. So all of the results of these trials preceded that immunotherapy data that was just published a couple of years back. So here you can see they don't even give you a select. They're like, here's some options, do what you want. So even less guidance. I thought it might be helpful at least to show you the data we have from the sorafenib era to kind of understand what we're dealing with, and that the options here are pretty limited in general, at least following an initial tyrosine kinase inhibitor and sorafenib. So we'll just be a little bit briefer with these study reviews, but the resource trial looked at regorafenib. So this is another tyrosine kinase inhibitor. I'll show you a slight difference in mechanism here in a second, but it was compared to placebo in patients, 570 patients, 73 patients who were randomized to either regorafenib or placebo, but had to have received sorafenib in the first line setting. It was a phase 3 double-blind study. And the kind of interesting point. We had this trial open years ago when it was being run, and they had this criteria that patients had to tolerate sorafenib for more than 400 milligrams per day for at least 20 out of the last 28 days of treatment. So extremely specific criteria, just to tell you how toxic these treatments can be, right? Like if you have to particularly walk out the number of days in the last 28 days they have taken the dose, it means that you have a pretty toxic therapy. So patients with child class B or C liver disease were excluded, of course. And this is kind of the variability of the targets of regorafenib versus sorafenib. Again, we think VEGF is the key, but you can see there's a broader spectrum of targets that this tyrosine kinase has, including FGFR. Okay, so here are survival curves, kind of similar to the very first frontline sorafenib first-line trial. We have a median overall survival of 10.6 versus 7.8 months for placebo with a statistically significant hazard ratio, but not overwhelming, incredible improvements that we saw with some of the immunotherapy combos. Then Celestial was the second study. This is cabozantinib, so another tyrosine kinase inhibitor. Again, all of these were approved before immunotherapy was available to us. So phase 3 randomized, similar design, 707 patients, all progressed on frontline sorafenib. The key about this study is they also include a small number of patients who also had a second-line treatment, usually on a clinical trial at that point in time. So this included some people in the third-line setting, 2 prior cancer therapies. And this is another oral pill. They compared to placebo, still child class A. And you can see the kind of variability in targets here are just 2 unique targets, MET and AXL, which were not targeted with the other tyrosine kinases. And survival curves look pretty similar to regorafenib, 10.2 versus 8 months, and that was statistically significant in their design. I just point out this very small print at the bottom to show you here that the majority of patients in the trial had only received 1 prior line of therapy, and there's more convincing improvement in terms of overall survival for those in the second line versus the third line setting. But it is the only trial that has any data. The other thing to point out is that these drugs are very similar in toxicity. They've just kind of maybe slightly changed the order of these toxicities, but it's overall very similar to sorafenib. We have hand-foot syndrome, diarrhea, fatigue, blood pressure, low appetite, LFT elevations, and nausea. And then the final study that I'm going to breeze through with you in this setting is the one drug is tested in second line and beyond that is not a tyrosine kinase inhibitor. So ramucirumab is another IV VEGF inhibitor. So similar to bevacizumab, interacts with VEGF in a slightly different way. And I think the other kind of unusual or key thing to point out in this study is that they particularly used AFP as a biomarker. I'm a little skeptical because REACH2 followed REACH1, where they did not use AFP as a biomarker. So they kind of pre-selected their patients. In their first study, they found that was negative, just in general in HCC patients. They found there wasn't an overall survival benefit. And then they came back and did REACH2 with AFP greater than 400, and their study was positive marginally, which we'll see. But that said, it is one of the few studies that we have that has a biomarker to indicate, are there a subset of patients more likely to benefit from a particular therapy, which we like if we can find that. So another phase 3 trial, fewer patients, 292 here, but again, had to have sorafenib first line, randomized 2-to-1. This is an every 2-week infusion. And all patients had an AFP of 400 or greater, still child class A. They had a little bit more particular inclusion exclusion because of the stronger VEGF targeting. So varices requiring endoscopic treatment were excluded, clinically meaningful ascites, uncontrolled hypertension, just because of the mechanism of the drug. And then this is a monoclonal antibody that targets the receptor of VEGF. So just slightly different mechanism, but same pathway as Bev. And here, even less impressive. So we have median overall survival of 8.5 versus 7.3 months, but it met their statistical plan for their protocol. In terms of toxicity of this drug, there's less of that kind of day-to-day nausea, hand-foot syndrome, diarrhea, but here we see more of the bleeding events, hypertension, proteinuria, so clotting bleeding is kind of the key thing for this drug. So when we're thinking about second line, the key is none of these, we don't know what to do. None of these drugs are evaluated following the first-line immunotherapy combinations that are recommended in the first-line setting at our present day. I think the other piece is how do we integrate sorafenib and lenvatinib that were approved in the frontline setting if we're using an immune checkpoint inhibitor combination or a VEGF checkpoint in the frontline. And so the data here, I would suggest following sorafenib is pretty marginal. But there are, and pretty similar across the board, the things that kind of call out particular drugs. Cabozantinib has the data in the third line setting. Ramucirumab has a particular subgroup that has AFP greater than 400. And then I just list a couple of the immunotherapy drugs. So none of these drugs have had positive phase 3 trials. Nivo, Ipi, and nivolumab have actually not been tested in a phase 3 setting. These are just data from a phase 2 that received accelerated approval for the FDA to allow us to use them. But this was before the approval of atezo-bev. So this was in the moment where there were really no immunotherapies yet approved for HCC period. So that we expect could be reversing as we get more data and information moving forward. So anticipating those will probably not be options on the list very much longer. And then pembrolizumab was tested in the phase 3 setting, and kind of similar to the data with a single agent immune checkpoint inhibitor in the frontline, it didn't meet its primary endpoint for overall survival or progression-free survival benefit. And I think in both of these cases, there's still some clinical situations where we consider using a single agent immunotherapy, again, all having to do with performance status, underlying hepatic function, toxicities of other drugs. I think a recurring theme that we realize and that we hear from patients is that these tyrosine kinase inhibitors are significantly more toxic than an immune checkpoint inhibitor. So perhaps even if you didn't do better than the tyrosine kinase inhibitor, if you provide less toxicity, it might be more of interest to patients. I think what's next? I think the key things we've talked about a bit today, a big focus now are in the very early stage and early stage disease for adjuvant therapies, which hopefully are going to be coming sooner than later. And same with the intermediate stage. I think this is honestly an area many drug companies are pursuing in very different forms and ways. So I'm hopeful that you can see down here a list of just some, and this is out of date from 2 years ago. I'm hopeful within the next even year or two that we're starting to see these combination therapies with liver-directed. And then absolutely many ongoing clinical trials in advanced stage disease that are now trying to combine tyrosine kinase inhibitors plus immune checkpoint inhibitors, or new targets of the immune checkpoint, different from the CTLA-4, PD-1, PD-L1 group. Additional targets like LAG-3, TIGIT you might hear about that are being investigated as well. And companies are very eager because of the success of other immune checkpoints in HCC to include these patients for the first time ever, I would say, even in early phase clinical trials. So we do have a lot of options for advanced stage patients for now standard therapy, but also for treating patients in the metastatic setting, and love to see your patients, especially with advanced stage disease, at any time. So I think take-home points for you guys, promising early results from our early stage disease, early and intermediate stage disease, but nothing practice changing to date. Advanced stage disease, I think it's a little bit confusing. We've got more options than ever, but hard to know exactly how to sequence and exactly which is the best. At this point in time, atezo-bev and tremi-durva are both equally considered first-line options. Typically, my choice is based on the clinical presentation of the patient to try to choose between them, since each were compared to sorafenib and not each other. Lenvatinib and sorafenib are options for toxicity concerns, and definitely my fallback for patients who have had prior liver transplant or significant autoimmune disease. And then I used durvalumab as my next choice in certain circumstances with single agent nivolumab for some child B patients because of most data there. And then in second line setting and advanced stage disease, we know there are multiple tyrosine kinase inhibitors that can improve overall survival following sorafenib, but have no known sense of sequencing after atezo-bev or durva-tremi. I would say in this setting, typically my approach is to say, if you got atezo-bev or durva-tremi in the first line, we try a tyrosine kinase inhibitor next, but there's, which one and how do you sequence is really unknown. And then I think the last thing that I always come back to, because, the majority of patients I'm seeing walk through my door are not child class A, ECOG performance status 0. So is there still a benefit to these patients that have underlying more severe underlying liver disease or borderline performance status? And I think when I'm seeing those patients in my clinic, I consider the places where we have the most data in terms of medical therapies, nivolumab and sorafenib for child class B. And that's all I
Fantastic.
have. Glad to take any questions. And I just left here my contact info. And also just wanted to bring up, anytime you guys have a patient with cancer diagnosis that you guys would like us to think about or review in our multidisciplinary clinic, please reach out. Catherine is the new coordinator for the liver MDC. So happy to take questions.
That is very important. I'm going to scribble that down. Thank you for all the data and the practical information. I guess I'd just start out. I don't want to monopolize all the questions, but you'd mentioned that obviously there's a lot of risk and concern for treating patients with checkpoint inhibitors post-transplant. And there certainly have been cases of fatal rejection leading to graft and life loss reported. I guess the question that we run into more frequently is those patients that we're trying to get to transplant, that especially those that have been downstaged into Milan, is their safety. Anecdotally, from asking colleagues around the country, I think most programs are cautious. Some will allow checkpoint inhibitors, but hold it at least 3 months. I know there was a paper in liver transplant last year that showed that those that had received checkpoint inhibitors within like 3 weeks and compared to like 8 weeks had a significantly higher risk of post-transplant rejection. So I had a patient that we were thinking about maybe 3-month window without it. And obviously with HCC, we have some idea of when they're going to get transplanted as they're occurring their 6-month time period. I don't know what your thoughts are on whether we should be considering patients for transplant with systemic treatment or
That is a fantastic question. Definitely comes up in the multi-D on our side a lot too. I think our concern always on the med-onc side is the data you've voiced, which is the risk of rejection, transplant graft rejection, which has been, studied across all transplant grafts. I think, and also in the metastatic setting. So there are, to my knowledge, I think 2 ongoing clinical trials that are looking at immune checkpoint inhibitors as a downstaging approach prior to liver transplant. So I'm hoping in coming years we'll have more data, but that could take years. And until that time, I think we are always very hesitant. I think what I would typically say is if we really think there's 0 chance that this person's going to get a transplant, if we don't do this, then why not try? But I think if we feel like there's other ways that we could stabilize the person with the tyrosine kinase inhibitor, that's kind of typically in the absence of data and known risk of rejection, that's kind of been our concern and our treatment of choice. But absolutely for individual patients, we're willing to try as long as you guys on your end are comfortable. I think the truth is, what is the treatment most likely to downstage these patients, right? It's immunotherapy, because we saw the most response consistently in all the trials with immunotherapy, even single agent versus tyrosine kinase inhibitor. So if we're really trying to get them downstaged, it makes the most sense. We just worry about that rejection risk.
Absolutely. So do we.
Right.
Does anybody else have any other questions for Lindsay?
That was awesome, Lindsay. This is Whitney. I'm sorry that I can't take myself off of, I don't know why my camera doesn't work 50% of the time after years of trying to figure out this thing. But yeah, that was just going to be my inquiry too about downstaging, how we can integrate these. And I think a lot of it's TBD, but I think we're all really excited about it. My experience with the HCC patients too is like, either they're getting all their imaging every 6 months, like we're asking them to, or else they've kind of been lost to follow up and are coming in a lot sicker. And so have a lot fewer options, unfortunately, when it's a lot more advanced.
Right. Exactly right. And like historically, that's when we met people, right? Is they're so sick. And now it's like, oh man, your child C, I don't think I can even offer you anything. So that's always the hard piece. And I agree too, and I think too, if you guys are really interested in a more universal adoption of trying to downstage people with immune checkpoint inhibitors. I am definitely for it, as long as we're all kind of on the same page and have some kind of protocolized approach to it. Our team in general is always going to say no, unless, you know, we hear from you that it's like, yes, we're totally for this. We know the risk and we're on board because we think this is the last option. So I think that's mostly, we just don't want to mess something up. It's really
Can you think of
we
any,
approach.
can you think of any examples of patients that, you know, you've been able to downstage and refer to us for transplant, like outside, you know, we use local regional
Right.
therapy all the time, don't get me wrong, but I mean, something that seemed a little more outside of what you typically see, and using systemic therapy, it seemed to help them get to transplant. I can't think of anybody.
No, I have no one. But the other piece, of course, is we're usually seeing, like, the people I have who are on long-term immune checkpoint combos are people who have infiltrative HCC.
Yeah.
You know, it's not the people who could probably be downstaged anyway.
Yeah.
And I think that's also on our end too, because we'll see them and we'll be like, well, do we want to submit this person to a treatment that's lifelong, right? Because it's not like we do this for 6 months and stop. Like, if we have an advanced patient, we're just treating them as long as they're stable. Versus doing liver-directed therapy where they're going in every few months. And if that's effective, we kind of tend to go that way. So that could be another area that we think about as well. These patients who are more likely to be downstage, trying that out. And I think that's coming with the intermediate stage data, and hopefully this trial will be opening too.
There's actually, you know, JP, I'm sure that you know about this, like how Anjana does that HCC tag conference that's coming up at the beginning of February. I'm sure I'm going to be in clinic and can't go to it. I was thinking it might be really interesting to go and just see if, you know, how aggressive they're being with transplant, but I'm not sure how much of that conference is transplant versus systemic therapy. I'm not really sure.
Yeah, I've never been either, but a lot of people tell me, like, I think it's like, I talk a lot to companies. They are all going and they recommend, they think it's the best meeting for HCC right now.
Oh, really?
So I think, who knows what their perspective is, right? Like, because they're talking about their drugs, I'm not sure. But I have thought about that too, just because I think it is a place where there's more interface between med-oncs and hepatology side and transplant.
Yeah, like
Julie,
I'm looking at the agenda, and you know, one of the first talks is liver transplant for HCC pushing the boundaries.
Yes,
You know, like,
there we go.
and then adjuvant therapy, neoadjuvant. So I do think that might be something that Colorado as a group could really learn from, honestly.
Yeah, I love it.
Yeah, Julie Humbach is one of the course directors in addition to Anjana. She's a transplant surgeon at Mayo. So
Yeah.
Nice.
yeah, no, I think Anjana has pushed, you know, a multidisciplinary approach. So I've never gone to that meeting, but yes, I hear good things about it. But
I just saw that it's also virtual, so I was like, huh, I wonder if I could kind of
do both.
She moved it from Utah to Huntington Beach this year.
Oh, that's an upgrade.
Sounds nice.
Yeah, well, Utah was actually too expensive, so yeah, I'll get there someday.
Yeah, it has like the I Am Brave 151. You know, I don't know. It might be interesting. Anyway, I think it's like a really awesome area for us all to be collaborating.
Yes,
like
absolutely.
thinking about expanding in the future, and probably will depend on some of those studies that you were talking about of the earlier stage stuff.
Great.
Thanks for the talk, though. It was really nice.
Yes, good. I'm glad.
Anybody else?
Lindsay, thanks for the talk. Yeah, this is Avash Colorado. Hi, Lindsay. Thanks for the talk. How's it going? So I'm not going to turn my video on either, but that's because I'm driving. So my question is, you mentioned kind of the study that you and John are going to be doing, combination therapy with Y90. I mean, I guess I'm curious what your thoughts would be about patients who you know, decompensate clinically on Y90, which I imagine is why a lot of the studies use TACE. You know, so perhaps the patient would become a child B or C and no longer qualify. I'm curious how that might be approached.
Absolutely. No, I think that's exactly right. And I think that is why not all companies are jumping on the Y90 evaluation bandwagon. I think so we had the Emerald 1 study with TACE open and we enrolled 0 patients. So I think the company saw sites like ours where it's just there are regional differences in terms of the preference of TACE and Y90. And so I think that's why a few of them have realized to get a better uptake of this kind of approach that they need to study it in different areas. But I think that's exactly right. And I think something that, you know, why it didn't, we didn't evaluate it first in that setting because of discomfort about the limitations then for future therapies down the road. Like, are we going to take a person who maybe would have been okay for years even getting liver-directed therapies alone? Are we going to transition them now to a person who's so sick from what we've done that they're not even a candidate for other systemic therapy and definitely not more liver-directed? So I think that's going to be the key piece that people are interested in. And is something too that we kind of talk to patients about when approaching them regarding the study of that significant risk. But I think it's a great point.
Yeah, well, I think it's great that you guys are going to start up the study. Thanks again.
Yeah.
All right. Well, I think that concludes it. Thank you again so much, Lindsay. I
Yeah.
really appreciate it.
Thanks, you guys. And like I said, happy to chat anytime about patients or help navigate getting them into the multi-D if needed on our end.
Perfect. Thank you again.
Thank you. Have a
All
good
right.
one, guys.
Bye, guys.
Bye.